So ultimately, people have tried this and that, and it's still not helping, and they're still very incapacitated. So I suppose at that point, you'll recommend joint replacement.
Yes, before we jump on to that, just another word on these non-operative measures. There are people out there who believe in stuff like using MRIs, doing other kind of procedures. Most of them are unproven and not widely accepted. So there will be people that will advertise and they will say we can do, say, MRIs or some magnetic energy or other stuff. Um, they are not mainstreams, and it's anecdotal, and they are expensive, and I don't think you will see much benefit. And they're all out there, and we, because it's such a common problem that we are all working to find an answer. So people sometimes are clutching with two straws, and but remember that your chances of success with them are low. Moving on to now, you started with physical therapy. You did that for a couple of years. Pain got worse. Then you went back and got an injection. Injections now, if I got an injection in my knee and it helped me for a year or maybe 2 years, maybe longer, and my knee starts hurting again, I can always get another injection. And if it lasts another 2, 3 years, maybe I'll get another injection. So injections are not a one and done thing. It can be done serially. And depending on how much response you get, because if I get the injection in my knee and my pain just goes away temporarily and comes back within a week or two, then it's really not helping. And if I get another injection in 3 months and it doesn't help, then I think you know that it's not going to go well with injections. So that's when I would stop the injection train and track, and then look to other options. The most lasting pain relief that you can get, and the most effective way of relieving the pain, is certainly a joint replacement, but only when you have failed the other options. And also, you should be a candidate for it, meaning ideally you should lose weight. Ideally, you should not have other medical comorbidities like diabetes. The worse your diabetes is, the higher your risk of infection. And we do check hemoglobin A1C levels before we embark on that road, which is a measure of your long-term glucose control with diabetes. So the diabetics, the biggest problem is that they have higher blood glucose levels. And so you need to have that under control. You have to have your medical doctor manage that. And once you got the other issues can be like if you have kidney failure, liver failure, or other organ issues, the more organs that are affected, the sicker the patient, the more the complications associated with an arthroplasty. So it's like preparing for a race. If you're going to get surgery, you get yourself readied for it, and you work to make sure that you're healthy enough to undergo the procedure. And so yes, and you also need to understand why we are talking about a joint replacement, and that is, the issue is that the cartilage is worn away. We're not getting it back. So an arthroplasty is basically, arthros, we said, was joint, and it's a plasty, or changing a part of the joint, or resurfacing the joint, is what a knee replacement is. It's essentially you're changing the lining mechanism. So instead of cartilage on cartilage, now you have metal on plastic, and they both are fixed to the bones on either end, and that's what takes away the pain, because now you don't have the bone rubbing against bone or the worn cartilage inflaming the knee joint. So that's how it works. Aligning it correctly and getting it fixed to the bone, it's as simple as that, and you're good to go.